So, good afternoon, all. So, our study is on factors affecting the non-adherence to anti-VEGF therapy in patients with diabetic macular edema. So, as we all know, diabetic macular edema is the accumulation of excess fluid in the extracellular space within the retina in the macular area. And anti-VEGF therapy has emerged as a standard treatment for diabetic macular edema. But despite proven efficacy, poor treatment adherence remains a significant challenge affecting visual outcomes in DME patients. So, going to the administration protocols. So, we will be having an initial protocol and a follow-up protocol for the patients. In initial protocol, it may be either a loading dose protocol or a PRN, that is Prorinata. In loading dose protocols, we will be giving an initial 3 monthly injections to all. And in Prorinata, we will be giving injections according to the clinical disease activity of the patient. In follow-up protocol also, we will be having either PRN or a treat and extend protocol. PRN we have already told. And in treat and extend protocol, we will be giving initial monthly injections till no disease activity is seen, and injections will be given at every visit but with increasing follow-up intervals. So the aim of our study was to evaluate the causes of poor compliance with anti-VEGF therapy in DME patients and also to assess the influence of the various dosing regimens and the type of anti-VEGF used in relation to the compliance issues. So we have studied 160 patients who was diagnosed with DME with clinical findings OCT or FA and were initiated on anti-VEGF therapy. And their demographic details, eye status, treatment strategy, anti-VEGF use, follow-up details were collected. And the patients were followed up for 12 months, and those who failed to follow up were contacted by phone to determine the reasons for non-compliance. And in our study, we have defined non-adherence as missing more than or equal to 2 treatment or monitoring visits over 12 months, with a visit considered missed if it exceeded more than 1 week from the recommended date. So coming to the results. So in our study, we have found that more than half of the patients, that is around 55% of the patients, failed to maintain adequate compliance with their prescribed anti-VEGF treatment regimen. And the major reasons came out to be other systemic comorbidities, which accounted for around 25%, closely followed by non-affordability of accounting to 21.6%, and no improvement in vision accounting to 18.2%, and no visual complaints also came out to be a main reason, around accounting for 10.2%. And other secondary reasons included health insurance related issues, the shift of residence of the patients or lack of bystanders, transport issues, etc. So going to the age distribution and age-related adherence pattern, when we compare the age pattern, there is a trend towards decreasing adherence with advancing age. And when we compare the gender-based distribution, there was a balanced distribution in our study between males and females, and male patients demonstrated better adherence rate when compared to female patients, which was approaching significance. And when we patient categorize, we have categorized the patients in our study into old and new patients. And old patients mean those who had already previously had received a treatment and they were familiar with the treatment strategy. And new patients, they were treatment naive. And when we analyze their adherence, old patients with prior treatment experience had demonstrated a significantly better adherence rate when compared to new patients. And anti-VEGF medication distribution in our study was ranibizumab was the mostly prescribed one in our study, followed by aflibercept and brolucizumab. And when we compare the adherence based on the anti-VEGF type use, there was no much statistical significance. Ranibizumab users showed a higher non-adherence rate, maybe because they were prescribed more. And brolucizumab users were very small in number, but they showed 100% adherence, though a small sample size. And when we compare the initial treatment protocol and their adherence basis, in our study, the majority of the patients were under PRN protocol in the initial strategy, and only around 4% received loading dose protocol. And all patients who received the loading dose protocols were found out to be non-adherent in our study. So coming to the treatment switching patterns, in our study, majority around 92% were continued with the same anti-VEGF agent, and only around 10% needed switch. And the main agents which were switched were to Azudex, dexamethasone implant, or an aflibercept. And when we compare the adherence between the patients who were switched and non-switched, the patients who underwent treatment switching showed remarkably better adherence rate compared to the patient who didn't require a switch. So this is a comparison of the number of injections the patient took before becoming non-adherent. here we can see an early discontinuation pattern. That is around 71.6% of the non-adherent patients discontinued within the first 3 follow-up injections. So our study was a prospective study which was conducted in 160 patients with a high non-adherence rate of 55%, and the main reasons for non-adherence been other comorbidities, non-affordability, and no improvement in vision. Another similar study by Bolhesen et al., which is also a retrospective study, showed a similar non-adherence rate of around 64%, with reasons being the cost problems, planned number of injections. And Indian study by Aditya Kelkar et al., which is also a retrospective study, which showed a similar non-adherence rate of around 52%, with higher reason being the non-affordability. To conclude, we had a high non-adherence rate among the patients with an early discontinuation pattern with multifactorial causes for the non-adherence, with significant associations in patients who are previously treated showed a good adherence. Treatment switching patients also showed a good adherence. Loading dose protocols patients were very poor with the adherence, and advancing age and female gender were also determinants for non-adherence. So our take-home message may be, a healthcare system should minimize the financial barriers and should provide good patient education and should provide a coordinated care approach with flexible treatment protocols for better anti-VEGF adherence. These are my references. Thank you.
Medicare tried all that which you have suggested. All your recommendations, use Medicare said. It in fact provided to all its citizens. Any number of injections you can give, whichever injection you want you can give, and yet it went down the drain. In fact, then only it commissioned the CAT trial. Go find out, go read about the CAT trial, and try to understand what made US to do the CAT trial. Okay. So those recommendations which you have brought, we don't concur with, because when there is no, you yourself saying no visual improvement, economical difficulty because of what is the cost of brolucizumab?
Brolucizumab around 40, sir. 30 to 40. Yeah.
So these were the factors which affected patients' non-adherence. They didn't want to stay sick. They wanted cure, but you created hindrance. It's not the patient who created hindrance. In fact, your treatment protocol created hindrance because it was a bit beyond his reach, and that is what happened. Had you switched to bevacizumab in these cases?
No, sir.
Had you switched to bevacizumab in these cases, when there was financial difficulties and non-adherence, when you are given an option 2 or a fallback to these patients, I am sure they would have taken and they would have got better. Point number 1. Point number 2, when you are saying non-adherence is a big hindrance, then you will have to have a RCT style study where you prove that adherence always creates benefits. Your study doesn't show that. Your study doesn't say how much of your study population exactly obeyed whatever you said and ended up with good vision. I'm sure there is no concrete outcomes in that side also. So when you are claiming that non-adherence creates difficulties, then obviously you'll have to, the vice versa should be true, no? You should prove that adherence creates good benefits. You aren't even proving that. And second, these trade names tend to avoid. Whenever you are making studies, keep generic molecular names into that study and don't keep trade names.
Thank you, Dr.